Hi everyone, we're the West Lancs gang, and we're going to talk about our project in Skelmersdale. I'm sure you probably do know where Skelmersdale is, but out of the Lancashire picture there, we're down at the bottom corner, West Lancashire. The picture on the left, on the other side, is the West Lancs outline, and Skelmersdale is the orange patch in the middle. So we're going to tell you about our project there. I'm here with Sue, Rachel and Lucinda. We're going to contribute as we go along. The West Lancs area has got 3 primary care networks. Skelmersdale forms its own, and there are 7 practices in Skelmersdale. So is this my next? Okay, so a bit about Skelmersdale then. Of the 7 wards in Skelmersdale, 6 are in the top 20% most deprived nationally, and 4 are within the top 5% deprived nationally. So high levels of deprivation. Along with that comes poverty, which we know impacts on health and well-being, and there are a lot of health inequalities in Skelmersdale. We have done some previous work over the years highlighting various issues, and respiratory has always been an area of concern for our area. So this graph here shows the wards across West Lancashire and highlights the emergency hospital admissions for COPD. As you can see, there are some orange bars on that side of the chart. They represent the 7 Skelmersdale wards. And the fact that they have red lines around them mean that they are significantly above the England average for hospital admissions. The England average is the red line that you can see going right across, and the Lancashire average is the grey line slightly above. So Skelmersdale's got a real issue around COPD admissions. At the other end, we've got some of the other wards with the blue boxes. They are significantly below the England average. So we've got massive variation in West Lancashire around our COPD admissions. Now, the GPs in Skelmersdale will tell you that we see a lot of COPD. We also see a lot of other chronic conditions, and particularly mental health. So we were interested in having a look to see how our hunch around mental health being important as a comorbidity, how that actually played out. And the data that we got actually bore this out, in that our top quintile for COPD has a depression prevalence recorded at 20%. That's the recorded prevalence. We know that the actual prevalence is likely to be very much higher. And as you come down the quintiles, the 4th quintile has got a recorded prevalence of 15% and the 3rd at 11%. So it starts to jump up at the 3rd quintile. Interestingly, when you look at some of the other comorbidities, diabetes actually has very similar comorbidity rates with COPD, around 20% in the top quintile, about 13% in the 4th, and again about 10% in the 3rd. We've come together, as we all have, and we've produced some interventions on both an individual and on a patient group level, and Sue and Rachel are going to tell you a bit more about that. Oops, sorry.
So I'm Rachel, I'm a nurse, practice nurse, and I've been involved in doing the individual interventions. So it's been around developing a new template for practice nurses to use for the COPD reviews. So it's a more comprehensive template, more holistic, instead of just like looking at QOF, just make it a lot more comprehensive, looking more at the management of exacerbations, making sure patients know how to manage your exacerbations properly, use rescue packs, recognise when they're having an exacerbation, looking at making sure that they're on the correct inhaled therapies, and with links to evidence-based guidance for the practice nurses to use, but looking a lot more about the depression and anxiety really, social prescribing, those sorts of needs. So we've seen 13 patients so far, and it's been really interesting really to look at the depression and anxiety, seeing how much that it is such a massive part of, has a massive impact on patients with COPD. I've been able to refer them to IAPT, social prescribing, get them reviewed for the, refer them back to the GPs for reviews if they need it. So it's just looking at them more holistically really. We've been able to get more support from IAPT and social prescribing, mental health services, social services, and we've developed a more clearer pathway through primary, community and acute care, and we're in the process of developing that pathway. And one of the things as well we've identified a need for is the letter that Barrow described. We're going to take that on board as well, so getting the patients in the first place, making sure that they know why they need to come in for the COPD reviews. So we've been using PAMs, so using those before the patient comes in for their review. So we're going to use that as a measurable outcome. So following them up in a month and then again in 3 months. And then other measurable outcomes we've been using are like the CAT scores, PHQ-9s and GAD scores as well. So we're going to use those to see how effective this new template is. And the plan is, once we've tweaked it and made any adaptations that we need, we're going to roll it out to Skelmersdale locally. And then the plan is to roll it out to the whole of West Lancashire so that the care is more streamlined and we've got a standardised practice and improve the quality of care for the patients. Okay.
So my name's Sue Hill. I'm an AMP at Beacon Primary Care. I work with Ros. So our plan was to develop group consultations. So first of all, we reviewed the evidence around the positive benefits of group consultations in terms of both patient satisfaction and clinical outcomes, but also staff motivation. So we designed the sessions to be a social event with healthy snacks, and it includes education. So the first section is about education, and then we break out for short 5-minute one-to-one consultations. Before the actual group consultation, they also have a 15-minute appointment with a healthcare assistant who gathers the data, takes the bloods, does the blood pressure, weight, etc. So when they come along to the first group consultation, they get a pack which includes all the recent results. We develop group discussions about diet, you know, what it's like to be diagnosed with diabetes. We go through the individual patient packs, which also include a notebook so they can write down the individual goals, because their goals might be very different to the ones that we want to achieve. And we also have a results board. So it's anonymised, it's A, B, C, D down. So we're not naming or shaming the patients, but they can compare their results with the other members of the group. And it enables them to benchmark their individual clinical parameters against the rest of the group. And that's been really useful because we've been able to explain each level. So, you know, what is a HbA1c? Surprisingly, a lot of these patients still don't know what a HbA1c is. So it's been an opportunity to really explain what the results mean to a group and have that time, because you've got a 2-hour group meeting, not a 10-minute, 15-minute consultation. So and also we discuss renal function and also go through medication used to treat diabetes rather. We're also using patient activation measures, which have been very interesting. Our practice has 4 sites across West Lancashire, and interestingly, two of the sites we've used for the group consultation so far have very different average patient activation measures. One was 2 to 3, the other one was 1 to 2. So we're getting a feel of what these patients in different areas need. So the next group session we're planning is for patients with COPD and depression, supported by interestingly, a long-term conditions IEP specialist who's going to be working in the area, is very keen to support us. And also we've had support from our respiratory specialist nurse who's going to provide support in sort of basic breathing exercises. And also even today I've had an email from someone who works with social prescribing about maybe developing a patient support group on diabetes and providing education on diet, cooking lessons for patients with diabetes. So more and more as we work together, we're developing these links with other agencies, which is really interesting. So what have we learned from applying a population health management approach? So the learning sets have been very useful. It's actually focused what we need to do and accelerated the pace of change. We're getting closer to the data, we're drilling down, so not only are we identifying respiratory as being a problem, we're looking at the comorbidities that Ros discussed about diabetes and depression. Clinicians are working along analysts. We're taking in expert advice, for example, the pharmacists, respiratory specialists, nurses. We're really using the data to understand areas of potential good practice and the opportunity to share again across the primary care network. And we're very much defining the population within the neighbourhood and where we need to target. And interesting, at the beginning of the learning sets, we found this patient who was having numerous hospital admissions, which had actually cost £74,000 in 1 year. And we were struggling to get, because it was anonymised, we were struggling to find out who that patient actually was, but we have managed to find who that patient is now, and we're informing the GP practice so they can do something about it and look into that patient in a bit more detail.
I'm Lucinda MacArthur, and I do some advisory work for West Lancs CCG. And just to focus, just for the last few minutes, I'm very conscious we're between you and your lunch, which is not always a good place to be. We're really focusing now on what's going to happen after week 20, as I know most people in the room are. I suppose in a way we're fortunate because in West Lancashire since 2014 in our clinical strategy Building for the Future, population health and population health management played a part. So as we talk to our MCP executive about the next steps and how we replicate this and scale, I think we're in quite a good place, and I think we're pushing it on a bit of an open door, really. But specifically, we'll look to deepen the work in the two practices that have been involved, particularly looking at the so what out of some of the interventions. That's going to be very important as we start to engage with other neighbourhoods who we're going to take on this journey. The Optum analysis has been very powerful. I think in there, there's more we want to get to. We've got that £74,000 patient. We want to make sure they're being supported appropriately, but we have quite a significant number of other patients that came out in that financial distribution that are costing a lot. So we'll be wanting to look at some benchmarking against that and how do we find a line at which we use that to make sure that those patients are getting the appropriate care that they need and they're reaching the outcomes that they can. I think some of the other Optum analysis that we've got around some of the Sankey diagrams will be an important part of that, where we've got patients moving in between some of those quintiles and what's the opportunity for intervening. So I think there's more to go at from what we've got and what we've been given for the two practices that have been involved, and then importantly how we share some of that for the remaining practices within the Skelmersdale primary care network and neighbourhood. We'll then look to how we replicate that model into other neighbourhoods. We've got a focus in our MCP executive at the moment around frailty. One of our neighbourhoods in particular has significant characteristics around frailty. So does that make the case for that one particular neighbourhood being the next one that we focus on? We're looking timescale-wise to maybe replicate that from the autumn. I think one of our points of learning has been that we had to mobilise clinicians very quickly and sometimes on a week-by-week basis, and that's really difficult. So we want to take the summer to do a little bit more analysis of what we've got afforded to us anyway, like other areas have, and get that ready, but also give clinicians a lead-in with forward planning for dates, so we can almost say to them, here's what it looks like for the 20 weeks from September onwards, so you can plan clinical cover a bit more effectively. We still have some of the backfill money that we've protected to allow that as well. It's not all of the answer, but it's an important part. We will look to bring local authority data into that. Our local authority partners at both tiers are around our MCP executive table, and I think some of the learning from Chorley and other areas is going to be really powerful to us as we reflect that in our replication plan for what we may be afforded to do. In terms of, we want to look at education from quite a basic low level for practices, a whole scale practice over an hour all the way through, and Edge Hill is one of our partners that's been with us on this journey from the beginning, and they'll be an important part of what we put in place around that. We're looking to develop tools that help us spread the message and looking for use of IT for how we spread some of that. And Ros will show you one of the tools that we've developed so far that will help articulate the process to some people who will be newer to this. And now we know what's involved. Like I say, we want to plan, but we also want to plan it in terms of what have we learned for our MCP and our primary care network and our neighbourhood development more broadly. So we have a care coordination hub in place now, but we want that to move towards an IT-enabled one. So what does that mean in terms of data? What does that mean in terms of what we do and don't get from the CSU? What does that mean for secondment agreements that we may need to look to for some of our analysts and more? So that just gives you a little bit of a flavour. Cutting through all of that will be the champions that we'll look for. I think some have really been surfaced through the week, through the 20 weeks and through the learning set, but champions we feel in all parts of the workforce are going to be a key part of this in order to embed it so that eventually cut us through the middle and this runs through all of us. So sorry that's whistle stop, but I know you can smell lunch. So. Sorry.
Okay, so what will be different? We hope for the person living with a chronic condition, they're going to be better informed. We're going to appreciate what's important to them. They're going to understand what it is that they need to do to help to self-manage their condition. We're going to be adhering to gold standards in terms of the evidence around our management of COPD, looking for preventative care and how to use that. So better for the patient. Hopefully positively impacting on the GP capacity and positively impacting on the hospital admission rate. Spreading the population health management message, as Lucinda's outlined, and improving, streamlining, standardising care across the patch. I think they're the key points for us. We did have a piece of work done by Matt, an artist, to try and bring all of this together to help us to communicate, because we know the big ask now is spreading it out. And here it is. It's beautiful. It'll take you a few minutes just to read through it all, but it probably we could just have put this up actually and not spoken to you at all, because it's all on there. And I think we'll leave you with that, or you ask us some questions if there are any.